This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our next speaker is Tony Williams. Tony is the Clinical Director of Acute Care at a very special place, Counties Manukau Middlemore Hospital in South Auckland. It's a pretty special place for a number of reasons. Firstly, my wife works there, so she sort of goes away and comes back again, which is grand. In addition, it's a place that's regularly looking after patients who are greater than 200 kilograms. I think even up to sort of 300. It's pretty remarkable. So they don't really bat their eyes at very much over there. And in addition, it's our National Burns Centre, and it's the latter expertise that Tony's going to talk to us about now.
Thanks very much. The title slide says it all. Obviously, putting out the fire is the first step in caring for a burns patient, often. But once they arrive at hospital, we've got a sort of faced with a tricky conundrum, really, and it's a bit trickier than I used to think it was. But to remind you all, in the 20s and 30s and 40s, there were some huge fires in the USA with mass casualties, and they were looked after by a few doctors who got to see the natural history of burns, and they realised that a burn injury caused fluid shifts that killed all the people with big burns in the first 48 hours. And if your burn is over 20%, you're going to get this burn shock syndrome. And your plasma sort of leaks out into your tissues and you become hemoconcentrated, you develop shock, and untreated that leads to death. And obviously we want to resuscitate people to prevent that happening. And fluids and burns has led to a massive reduction in mortality. So they are one of the keystones of our treatment. Initially people gave a lot of colloids, and at the time they were doing a lot of this research in the 50s. Plasma was one of the key fluids that they used to resuscitate sick people, and a lot of burns patients got given a lot of plasma. But we discovered that hepatitis was in some of that plasma, and some people got sick later, and it really through a fashion thing rather than due to any lack of efficaciousness. Crystalloids took over from colloids in the history of burns resuscitation, and all of the formulas we currently use are based on crystalloid resuscitation. Shires and Baxter at Parkland Memorial Hospital developed the Parkland formula, which replaced an earlier formula, the Brooke Army formula, and they both use crystalloid resuscitation. The original Brooke formula used 1.5 mils per kilo per percent burn of crystalloid, and half a mil per kilo of colloid, which was plasma. When they modified it, they just said we'll just give 2 mils per kilo per percent burn of crystalloid. And Parkland formula doubled that, really. And unbelievably, there's never been a comparison of these two formulas. Certainly not any formal randomised controlled trial. So the American Burn Association recommends you can use either 2 or 4 mils per kilo per percent burn. But all of these formulas were developed by achieving adequate physiological parameters. What we aim to do when we use a formula is to stop fatal burn shock. We want to prevent new organ failures developing, and probably the simplest way that you're going to be doing that, assessing that, is by monitoring urine output. So half a mil per kilo in adults and 1 mil per kilo in children. Okay? But there's no real data on whether those targets are correct or on how much fluid to put into our formula. Now, one of the good things to come out of US foreign policy in Afghanistan and Iraq is this study. I'm not sure if it's the only good thing, but it is shining a small light and has improved our understanding of burns resuscitation quite a lot. Because the ABA recommended you can go between 2 and 4 mils per kilo, the US Army told their medics to follow the ABA's guidelines. So they had an unrandomised natural experiment. They found 58 evacuated patients who had accurately recorded fluid data and had been treated according to these ABA guidelines. 6 people got 3 mils per kilo in the middle, so they excluded them, and the rest they were able to divide into 2 groups, the people who got the Brooke formula, 2 mils per kilo, and the Parkland group, who we started off giving twice as much. Not much to say on that really, but it's a small study. Baseline balance is a big problem, and you can see the burn size is not very evenly distributed. Okay? The Brooke formula patients tended to have more big burns, and the Parkland more small burns. And I'm not going to show you much on this, but just look, a lot of people got vasopressors, 2/3, same in both groups, and a lot of people got albumin in the first 24 hours, okay, about 50%. But this is what it illustrates, is that if you start aiming to give 2 mils per kilo, you end up giving 4 in the first 24 hours, and if you start aiming to give 4, you end up giving 6. And Basil Pruitt has called this fluid creep, okay? We're very good at responding to people not making their targets, and we give a bolus. Okay, urine's down, blood pressure's down, heart rate's up, we give a bolus. When someone makes their targets, we're nowhere near as good as titrating down our treatment. And we've got to remember these formulas are just guesses. They were made up on animals and validated on very few patients. Okay, they'll give you some rational place to start, but observing the patient is the key thing. And we've got to recognise that the more we give, the more we do. Now, there was no difference in outcome. Okay, it doesn't matter whether you start with the Brook or with the Parkland, the outcome seems to be the same. But interestingly, you give a lot more fluid. Is that extra fluid harmful? More fluid causes more edema. Basically, we're talking people who are getting 16, 20 litres of fluid in the first 24 hours. And we know that people who go over 250 mils per kg are at risk of abdominal compartment syndrome. Okay, there's nothing wrong inside their abdomen, but that much fluid in 24 hours can give you an abdominal compartment syndrome. I knew it was in the books, but I'd never seen it until a couple of years ago. We've seen them now at Middlemore. As we're getting better at resuscitating patients, we are getting into these problems. And unfortunately, if you get an abdominal compartment syndrome with a big burn, that's 97% mortality. Again, the Army reports these things. You're going to need more fasciotomies. More edema means slower healing, and obviously, especially in children, it can lead to dreadful respiratory failure. That can be hard to sort out when we're trying to debride the burn. People are going backwards and forwards to theatre. They've got big fluid shifts. They can have a lot of bleeding. If they start off way ahead on fluid, they can get into trouble. So I haven't got too much more to tell you, except to say some tips. We have to give burns resuscitation. Okay? Fluid is not bad. It's life-saving. Formulas are tricky things because they require accurate burn size assessment. And 50% of the patients who come to Middlemore, their burn is a wildly different size to what I get told on the phone on the first day. Assessing burn size is not easy, okay, until the London Browder chart is filled out by someone who's been to theatre and has actually mapped out the burn. It's a guess. Okay? So remember, you're starting with a crappy formula based on a guess. Okay? So you may not be giving the right amount of fluid. You may be giving too little, because deeper burns need more fluid, inhalational burns need more fluid, but you may also be giving too much, okay? And fluid begets fluid. That's what that Chung study shows us. The more you start giving, the more you're going to end up giving. Be prepared to titrate fluid down, okay? So if they're achieving their targets, the blood pressure's okay, they're passing urine, try backing off on the fluid, okay? Use boluses carefully, okay? The fluid's not lost instantly. Obviously, if the patient's got multi-trauma and they're bleeding, or there's something else going on, you may need to reevaluate that. And one thing I would say is watch the hemoglobin. If the hemoglobin is going up, you're probably under-resuscitating. If the hemoglobin's going down, something else is happening. Okay? Burns generally don't cause bleeding. So either there's trauma that we don't know about, some blast or something, or we're getting into something like an abdominal compartment syndrome. And if you don't think of it, the patient will probably die. Consider albumin. Albumin went out of fashion based on some pretty flimsy evidence, and I think after the first 8 hours, I would be very comfortable in people who are needing a lot of fluid and giving them a little bit of colloid as part of their resuscitation. Okay? Thank you very much. Like all things with fluids, you can have too much of a good thing.